We are now heading into our final session for our Smashers of the day. So, we are going to be discussing trail-tested treatments for brain metastases. And can I just say what a day it has been so far? This has just been really special and incredibly memorable and impactful for me, and I hope it has been for you all listening as well. And I think this last session is going to be another one to remember. So let me introduce our two lovely speakers who are going to be talking to us today. Dr. Zach Brownlee is a radiation oncologist with the Center for Cancer and Blood Disorders in Texas. Come on in. You're wanting to join us. Where he focuses on delivering personalized and patient-centered cancer care. Dr. Brownlee is joined by Molly Tate, a radiation oncology APRN at MD Anderson Cancer Center. She plays a key role in supporting patients through complex treatment journeys and has expertise in really delivering compassionate care for our patients. You can read their full bios on the app, but please join me in welcoming Molly and Dr. Brownlee.
Can everyone hear me? Perfect. All right, so thanks for having us here today. So this is an important topic in small cell lung cancer that I see a lot of in my practice, and I have a lot of nuanced discussion with patients about this. I tried to get into some details, but not into too many details. So if there's questions that come up about more specific questions about kind of the radiation techniques or the different treatments we're going to talk about, I'm happy to go over those in the end. Otherwise, I'll try to keep it kind of more superficial, going over everything. And we can start. There we go. So just some background. So when it comes to small cell lung cancer, and again, I don't know what's been discussed earlier today, but this is a cancer that is not the most common of the lung cancers. The reason why we have a session dedicated to brain metastasis is because brain metastases are a very common part of this disease trajectory. A good percentage of patients will have brain metastasis at diagnosis, and a high percentage of them will have that as part of their treatment course at some point. In general, across all cancers, we do see brain metastasis, and they can be something that can cause symptoms, or they can be something that we can find on imaging, but the treatment is directed towards trying to control the neurologic functioning. Especially in small cell lung cancer, MRI is our imaging tool of choice looking for brain metastasis. It's the most sensitive tool we have. PET scans don't image the brain effectively. CT scans are okay, but the MRI is the most sensitive tool. So this is something that most patients will get multiple surveillance MRI brains to keep an eye on the brain, trying to catch things before we have symptoms. When it comes to treatment for the brain specifically, I have a discussion that it's a balance of controlling the disease as well as controlling toxicities. Over the past 5 years, our small cell lung cancer treatments have become much more effective. We have patients that are doing far better, so thinking about side effects is a big part of the discussion now that previously was not as in the forefront as it is nowadays. So as far as tools, so when we talk about cancer care, we have kind of our three main tools for treatment, which is surgery, medicines, and radiation. When it comes to brain metastasis, we have all three tools at our disposal as well. Specifically for small cell, this is one of the few disease sites that we actually talk about preventative treatments, which we'll get into. And then imaging surveillance at diagnosis and throughout the disease course is important. When it comes to surgery for brain metastasis, for most histologies, this is reserved really for symptomatic brain metastasis. So if someone comes in and they're having weakness or vision changes and it's not improving with steroids, we do have surgery to try to remove the mass and the symptoms more quickly. But often this is something we try to avoid unless it's really needed, especially in small cell lung cancer. Chemotherapy, the traditional drugs, typically don't get into the brain effectively to have effective disease control. So it's historically not been a big part of the treatment for the brain. Radiation, which is what I do, is kind of the key tool, which is why I think they have both of us here talking about brain metastasis. So we have different ways of doing this, but radiation is often our main tool for treating cancer that's spread to the brain. When it comes to drugs, the newer systemic therapies, which Dr. Shields has probably talked about or is working on, they do have improved penetration into the brain. So these are things that we have more tools to use for brain metastasis, and we have to keep this in mind when we're balancing what treatments we choose to treat the brain with and thinking about side effects and control. In terms of the radiation tools we have, we're going to talk about some kind of buzzwords that you might see when you're reading or hear from your doctors. The first buzzword is something that we use in the preventative setting, and this is called PCI, which stands for prophylactic cranial irradiation, which is a mouthful, but this is trying to treat the brain before we can actually see cancer in the brain because we know there is a higher risk of it being there. Currently, small cell is the only disease we do this for. There's some trials in other histologies, but we currently don't do it as much. In terms of treatment, there's two main tools we have, which are both radiation but delivered differently. The traditional approach is called whole brain radiation. Like the name entails, we treat the entire brain. There's newer techniques, which we call hippocampal sparing, which is trying to avoid the most sensitive part of the brain when it comes to the side effects of treatment. And then there is a different approach, which is called SRS, or stereotactic radiosurgery, that is targeting only the lesions we see, which we do for a lot of brain metastasis nowadays, and this approach has good control with less side effects.
Just want to add, that's a good slide just to go in, to when you're seeing your radiation oncologist, that's like the perfect slide, right? Asking, okay, am I a candidate for this or this or this? Even, despite what you may have read online or someone has told you, I think I always encourage my patients to just ask questions from a balanced perspective, and our job is to give you the answer, why you're a candidate for PCI or why you may not be. But I always favor just asking a broad array of questions just like that. Like, here are the options. And really that applies to all forms of radiation, right? Am I a candidate for this? No. Check it off. Am I a candidate for this? Just so you feel more comfortable with what is proposed and recommended. And it's just going to make you feel more comfortable overall with the treatment that's being proposed.
So the first thing we're going to talk about is the preventative treatment, the PCI. So this is essentially a way of delivering whole brain radiation that is a slightly reduced dose with the hopes of trying to take care of microscopic or invisible brain metastasis that are in the brain that we cannot see. This is something that was initially proposed back in the 80s and 70s and had quite a bit of data that did show there was some benefits and patients did better if we did this treatment. The thought is the chemo and the radiation take care of the cancer in the chest, and then the preventative radiation can kill any microscopic cancer cells that might be hiding in the brain that the chemo didn't get to. This is a treatment reserved for patients with what we call limited stage small cell lung cancer, meaning confined to the chest, where they get curative intent radiation as part of their treatment. In general, this is an approach that is being studied if we can omit it due to some of the side effects that it can cause, which is part of the whole brain radiation picture. In patients with extensive stage disease, we have good data that if we just keep a close eye on the brain with MRIs, there's no loss in outcomes and we avoid some of the side effects of whole brain radiation. In the limited stage spectrum, this is currently being studied, but a lot of providers, myself included, are having kind of detailed discussions where I typically do not recommend it. I think I kind of went over these, but there's pros and cons to everything we do, which is kind of part of the discussion I have with patients. So most of the benefits of PCI is this is thought of as kind of the last part in the curative intent treatment of small cell lung cancer. There's a chance there's microscopic cancer hiding there. Again, some of the older data did show improvement in overall survival, which is ultimately our main endpoint we want to improve. And it did show that we had a lower risk of patients developing brain metastasis in the future. The cons are, again, the side effects, which my sequencing of my slides is a little off, but we'll talk about those later with the side effects of whole brain. But in general, this is a 2-week daily treatment course that does cause fatigue and hair loss, which is some of the temporary side effects. But some of the long-term side effects is it can have effects on your short-term memory, on your cognition. It can increase the risk of cataracts, which is not as big of a deal, but it's part of the picture. So some strategies that the field has employed is potentially doing this hippocampal approach, which we'll talk about later, to try to minimize some of those cognitive effects. There are multiple very smart people trying to use AI and other tools to predict which patients are the highest risk for brain metastasis and might benefit more from PCI. And then, again, the last thing is trying to omit it and use MRIs.
So from a, what to expect perspective, I always try to explain it like with any oncology treatment, the side effects are a spectrum. So often you fall, somewhere on that spectrum, but the person next to you receiving similar or the same treatment could fall somewhere completely different. So in general, when you receive PCI, you're going to feel fatigued. It's usually not so profound that you can't get out of bed. It's just, I may need a nap or a longer nap. I just may feel more run down than I normally do. Hair loss, specifically hair thinning, kind of generalized, is very common. Almost always it grows back, and sometimes it grows back thinner or maybe even a slightly different color. And then headaches. So that's pretty common just because of the inherent nature of radiation. It's inducing some inflammatory, swelling to an extent, right? So if you have a headache and it's the afternoon and you're going through treatment and you take Tylenol or ibuprofen and it goes away, that's fairly normal. It's usually, if I notice that my headaches are not responding to that or they're getting worse or more frequent, that would be something you'd want to let your care team know. And you're being monitored, throughout your treatment. You have access to your care team all the time. You have your weekly visits, your on-treatment visits, where the side effects are managed more formally. But one thing you want to make sure of when you start this is just what are the things I need to be looking out for or be aware of, what's normal and what's not. And if you're ever unsure, speaking up and asking is the best thing you can do. That way you can either be provided with the reassurance that this is normal or no, but we might need to start a steroid because you're having these more frequent, more intense headaches. Memory impairment is something that, sometimes it's hard to differentiate, right? Like, where'd you put your keys today? If that's just, we all have those moments, right? You're under more stress. There's just more going on. The fatigue can also kind of superimpose the quote-unquote memory impairment that might be related to radiation. I find that with our patients in our practice, that's something that usually manifests months after radiation, not necessarily during. At least that you can say is caused by the radiation. Kind of the same thing with the executive dysfunction and motor difficulties. Those are more chronic, but I would say the most common chronic side effect would be some of the acute memory recall. And we'll go into ways to mitigate that with a medication that we typically use here in a little bit. Right where it says avoiding concurrent chemotherapy, I know on a couple slides before that there was mention of most of the chemotherapies do not cross the blood-brain barrier, but there are newer medications that are being developed that do. And so historically we've kind of sandwiched this in between cycles if you're on systemic therapy, just to avoid extra toxicities. And then just want to mention up front, with any form of radiation therapy, if you've got a history of any sort of collagen vascular disease like scleroderma, rheumatoid arthritis, lupus, kind of along that family of disorders, a lot of those patients are on immunosuppressants. And so that's something that you want to be you want to tell your provider, and that's something that we check for so that we can appropriately manage you from a rheumatology perspective, because sometimes those side effects from those chronic disorders may flare during radiation.
So for each of these topics, there's active trials that are undergoing that are going to answer a lot of these questions. So kind of the big question in PCI right now is, do we need it or not? So there's multiple trials underway, some of which are close to accruing, and then we need some time to figure out the outcomes. They're asking all the right questions, looking at kind of disease outcomes in the brain, overall outcomes, cognitive outcomes, and then they're doing some more scientific things to really learn as much information as we can about this. So currently the best option, if available, would be to get on a clinical trial to try to help the field. I discussed these. Again, I don't have access to these currently, so I often will treat off of trial with avoiding PCI. So I had a slide on kind of what I do for each of these. So for my patients that are extensive stage or metastatic at presentation, I do not recommend PCI ever. I still get referred patients for this, and I just discussed, well, I'll keep an eye on your brain closely, and if it pops up, we'll deal with it. For limited stage, I look at a lot of factors, kind of age, how well they're doing, performance status, or how well they're getting around, how their cancer in the body is responding, what other treatments they're going to be on, and after that discussion, we'll decide if we think the PCI is worth it or not. And again, I typically tend to favor omitting it. Most patients are pretty beat up after treatment. Most patients that I see are older and have other comorbidities to where I think the risks of those cognitive effects outweigh the potential benefits. So the next technique, so these are treatments when we actually have brain metastasis. So the traditional treatment that we've used for brain metastasis in the past, and specifically continue to use for small cell lung cancer, is called whole brain radiation. I have some pictures on the sides of patients that I've treated where you can see we kind of block out the face and we treat the entire brain with radiation. The benefits of this is it will treat the cancer that we can see as well as potential cancer that we cannot see, just like the preventative medicine or radiation. This has been shown to potentially decrease the number of brain metastasis we see in the future. But again, the cost is the side effects, which are the same side effects we talked about in PCI. You get the temporary fatigue and hair loss, and the fatigue does tend to linger a little bit longer than other radiation fatigues. And then we do talk about the long-term memory effects, which are the main things that we're trying to avoid. When it comes to strategies to try to minimize these effects, they have learned that a big driver of the cognitive effects are the dose to the hippocampus, which is a specialized part of our brain that is involved in memory formation. The adult brain in general is no longer dividing and learning things like kids, so whole brain radiation is much less toxic in adults than it is in kids, but it does have these cognitive effects that we've known about and seen. Recently, we do have a couple of tools to try to help minimize this, and these have been studied and shown to be safe in terms of there's not worsened outcomes by avoiding this part of the brain, and they do have proven decreased risk of cognitive effects. These are often paired with a medicine called memantine or Namenda that is an Alzheimer's medicine. What I always tell my patients is this is a drug that helps prevent the progression of Alzheimer's, and it also helps protect the brain from the radiation effects, but the radiation does not cause symptoms like Alzheimer's. It's just protective for both of those processes. The worry of the hippocampal sparing is that the brain metastasis could pop up in that part of the brain that we avoid, but that's extremely rare. This is still considered controversial in the PCI setting, but we do have good data showing no outcomes, so I don't think it's really controversial anymore. In small cell lung cancer, technically the trials did not include these patients, so again, it is still controversial, but a lot of practices are kind of including those patients, myself as well. So the only reason I would typically not use this if there's lesions in the hippocampus that I feel like I need to treat and I can't avoid. Oops.
Yeah, just to piggyback on the hippocampal avoidance. So the risk of, or I guess the chance of having, brain mets in that region, correct me if I'm wrong, is probably less than 5%. I mean, it's very small, which is a huge advantage to this approach in the development of this strategy, because you can offer this to so many patients and really protect that cognitive function with the use of this concurrent memantine that you typically recommend twice a day for approximately 6 months. I think one of the most common side effects that we hear from that is nausea, which, if you've already been through the nausea from the systemic therapy and now you're dealing with this, I mean, there's only so much you can handle. So we do give steroids if we need to, and then antiemetics or nausea medications, which you want to try first just to see if you can handle it and if it's tolerable. Give it a shot, because it's really proven itself through some trials previously that this does protect that executive functioning, that acute memory recall, and is a very advantageous way to kind of treat the whole brain but preserve the small area that's very unlikely to develop a brain metastasis in the future.
Clicking too fast. All right, when it comes to our last approach, we call it stereotactic radiosurgery, which is a term that was developed when this first came out in the 80s, when neurosurgeons developed this device called the gamma knife that was able to treat brain metastasis non-invasively. This name has evolved over time, but this is a technique for treating the brain metastasis that we see. So I call it pinpoint or targeted brain radiation to my patients. This is something that we do for all different types of brain metastasis from all different types of cancers. This has become a common practice in general for a limited number of brain metastasis, so it's kind of a moving target. When I first started, it was kind of 1 to 10, now it's 1 to 20. Now it's kind of whatever you think is reasonable. We have new approaches and new machines where this is anywhere from a single treatment, typically all the way up to 5 treatments, based off the size and the location of the actual lesions you're treating. We have different machines that can do these treatments. If you've seen them, there's the gamma knife, there's the cyber knife, and then the linear accelerator, we call it a LINAC, which is the machine that every office has, is now able to do all of these treatments. So depending on where you see your doctors, they might have one of these tools. And I've used all 3, and they all do a good job. The pros of this approach, which is still controversial in small cell lung cancer given the high risk of additional lesions, but we'll talk about how it's used. The pros of this is it works really well. The control of each individual lesion you treat is extremely high, usually quote around 95% for most. It has very few, if any, side effects, which is pretty rare for most cancer treatments. It has no cognitive effects. It doesn't cause hair loss. You don't have nearly as much fatigue. Often we can do it in a single treatment, so it's convenient. So we can have patients come from far away and do a single treatment. Some of the cons is, again, we're only treating the cancer we see. We're not treating the potential microscopic cancer cells, so we are more likely to find additional lesions, but we have found that we can always come back and treat those once we see them. There is a question of, if we don't treat these right away, is there going to be worsened neurologic outcomes as far as weakness, numbness, seizures? Is there a risk of what we call neurologic death, or leptomeningeal spread, where the cancer spreads throughout the brain? And that's something that we have not seen increased risks in general in these trials. So I had a couple kind of just pictures of the different tools we have. Do you want to talk about gamma knife? Or?
You can talk.
Okay. So this is something they have at MD Anderson. They have it at UT Southwestern here. Where I trained, we had a gamma knife. So this is the first tool we had, and it's still arguably the best tool we have. This is a machine that only is used for treating the brain, and it's only used for treating very small lesions in the brain. So this is a device that is typically a 1-day treatment. You'll come in early in the morning. You'll see typically the neurosurgeon will place this frame on your head, which you can see in the lower picture. So it's kind of a metal rectangle that goes around your head. There are 4 pins that connect the frame to your head so that it will stay in place. This is our immobilization device so that your head cannot move during treatment. This frame will then fit into the actual machine, which you can see above, where there's radiation sources that through a small opening will deliver radiation that, just like spotlights on a stage, will pinpoint onto the treated lesion. After the frame is placed, you typically go to MRI. So they'll do a planing MRI. Then the doctors will plane it while you sit in kind of the waiting room, and then you'll lay on the table and you'll get treatment. Just like any type of radiation, you feel nothing. There's no cutting, no burning, no pain. The treatment can take a while with this approach, depending on how big the lesions are, how many you have, and how old the source is. But it's a single treatment. Then you get off the table, you take the frame off, and you go home. There are newer forms of Gamma Knife where we don't use the frame that most centers have nowadays too. And just like a LINAC-based treatment, these use a mask. As you can see in that lower picture, this is the mask that I use. So this is a little bit more rigid than the traditional mask so that we can have very good setups. The LINAC is a machine like you see above. Most of them are called true beams, but there's other machines where they will deliver radiation through x-rays that we can aim and shape and move around you. With the LINAC approach, we have the ability to do one or multiple treatments. Since there's not a frame involved, it's not as big of a deal to come back and do the treatment again. The treatments do tend to be quicker because this is not using a radioactive source. So we can usually do the treatments, whether it's one lesion or 30 lesions, in around 15 minutes. These are a little bit easier for patients to go through when it doesn't come to the frame. This is an area in the small cell world that is under trial. So we have some preliminary data coming out of University of Colorado that shows really good outcomes for SRS, but we are doing a big phase 3 trial where we can have better data to confirm that this is an ideal approach for patients. So on this trial, they're doing 1 to 10 lesions, and the comparison arm is what I talked about earlier, that hippocampal sparing whole brain radiation. So hopefully we'll have some data from this soon that will help us guide our practice. When it comes to my practice, so again, just like when we're talking about PCI, we look at a lot of factors. There's not a one right treatment option. It all depends on the patient. I always say I'm treating you, not just treating your cancer, so we have to look at different things. In general, I tend to favor SRS. The less number of lesions I see, the more likely I'll recommend it. If we see 15 to 20, it's typically not, in my thoughts, going to be the right treatment. So we will talk about whole brain with hippocampal sparing. The less lesions I see, the better the cancer is in the body. The more likely I'll recommend the SRS approach, with the caveat that we are likely going to see some more in the future. And if they continue to be sporadic, we'll continue to do SRS. If we ever do a scan where we see a lot, we will always have whole brain in our back pocket. And then if I do whole brain, I typically, like I said, recommend the hippocampal sparing unless there are lesions there or if we see something called leptomeningeal carcinomatosis. This is a field where there's lots of other active areas of study. There's a device called Optune, or tumor treating fields, that we use for brain tumors, and there is some data for brain metastasis. This is being studied in small cell, so if you have any interest, it's something we can look up. Most of the other studies are in Dr. Shields' realm, where we are finding these new drugs that have good efficacy in the body. They also have penetration and good efficacy in the brain. So again, more tools for treating brain metastasis. And then when it comes to leptomeningeal disease, I didn't get into it much, but there is studies of looking at protons, which is a more targeted way of delivering radiation to the whole brain and spine that is under trial. Anything to? Okay. Yeah, so just in summary, overall, too much. Sorry, it's being finicky. Very sensitive. All right. Overall, the field of small cell lung cancer it's a good field to be involved now. Outcomes are getting so much better. I have much more optimism and hope when I talk to patients, from reading trials, from my own experience, from patients that I've seen and treated that are doing great. We're looking at years now of patients doing well, which we didn't often have before. So when it comes to treating the brain, I do think this has become a more nuanced discussion. We really have to think long-term, not just short-term. The role of radiation for brain metastasis, which I always tell my patients, kind of irregardless, is my main goal when I'm treating brain metastasis is to keep your brain working like it is now. It is uncommon for patients to ultimately pass away because of the cancer in the brain. So we want to control the brain and keep the brain working well from disease standpoint as well as from a side effect standpoint. When it comes to all these different tools we talked about, there's a lot of gray areas right now because we're actively studying, as the field is changing, how to ideally treat the brain. So we will have good data soon that will kind of support and drive what are the right treatments or the kind of the most data backed up treatments. In general, the approach is becoming kind of less is more, less toxic treatments, more targeted treatments, more selective treatments. In the future, as the drugs continue to get better, there might be less and less radiation we need for the brain, which is always good. And currently, with everything, I think every patient is different, so every discussion with your doctor is kind of a discussion. So I think we need to know the options out there and then discuss with our doctors which options they think are best for you and why. And I think knowing some information on your standpoint can help make this discussion better. But I try not to tell patients what to do. I think it's a discussion, and then you know yourself the best, so we decide what you think is best for you.
Wonderful. Wonderful. Thank you so much. That was fantastic. I'd love to. I'm going to stand up so it doesn't yell at me. I'm going to move over here. Let's see. Are we better? Okay. Please send us your questions in the chat, and we'd love to have them. Before we jump into our online questions or questions in the group, what are some very practical ways our smashers or their loved ones can help prepare someone going through radiation or be there for someone who's undergoing radiation? What are some practical tools? How can we encourage patients as they're going through radiation or after they've had it to kind of a road to recovery?
I think, looking at or first deciding or understanding rather what it's going to look like, right? Are we doing this in one day? Is this going to be over 2 weeks? Just the basic things, transportation, meals, the daily tasks that we all have to do. What can I take away or help with so that you just focus on resting, and not just rest, but leveraging when you feel good. Because yes, rest is good, it's restorative, but when you have moments that you feel good, let's go for a walk, let's do something you enjoy, let's keep the momentum high. Let's be positive as well, because as you hear throughout this conference, there's so many new strategies that are being implemented with very positive foresight of what it's going to look like. And so just being that sounding board and solid support for somebody, as easy as that may sound, makes a world of difference. And then I think too, asking questions, because a lot of times, if you're undergoing these various treatments, you're just going to be wiped from time to time. You're not going to know what to ask. Being someone's advocate is huge. Asking the tough questions for somebody who either doesn't know what questions to ask or doesn't want to, I think that's invaluable.
Thank you, Molly. Anne, I think we have some questions.
We do. We have several questions. The first question that was asked is, can you explain what the term susceptible artifact on a brain MRI means, and is it something that should be treated?
I'm not sure I know.
I wonder if it might be a suspicious artifact, possibly?
Yeah, that's
suspicious artifact?
Yeah, when it comes to MRIs, again, it is an image. Just like any image, the radiologist can't tell you what everything is. Brain metastases are typically something we do not biopsy. Usually if you have a cancer that we know can spread to the brain and we see something that looks like a brain metastasis on imaging, which they're typically kind of spherical enhancing lesions, they tend to enhance more kind of periphery. We don't biopsy it usually to confirm. If it's someone that we don't know they have cancer, we often will biopsy the brain to confirm what it is. There are these small things we can see that could be a little kink in a blood vessel, or they could be just where the contrast looks a little funny. If this was the only thing we saw, I typically would do a repeat MRI in 4 to 6 weeks to see what it's doing. I don't always just assume that it's bad or assume that it's good. It's something that I typically would watch. If it's still uncertain and we really need to answer, you could always do a biopsy. If it's, again, a lot of times there's some uncertainty. There's different imaging tricks and tools we can do to try to get more information. But I would say it's hard to have a generalized answer for that.
I think that was a great answer. And again, we sometimes see this and we don't want to act too quickly too. I think we have to be cautious. And I just want to interject one quick question first. I think one topic that we sometimes see, and this can also show up on scans, it looks suspicious. Maybe there's swelling or irritation or growing area, and it might be radiation necrosis. Dr. Brownlee, can you speak to that?
Yeah, so I didn't get into that. So especially with the radiosurgery approach, the main side effect we see is that small part of the brain we treat can get injured by the radiation. And we call this necrosis. This is often symptomatic, where you'll have symptoms like there's cancer there, so you can get swelling in the area that can cause local symptoms, whether it's balance issues or weakness or headaches or nausea. With imaging after treatment of brain metastasis, especially with that pinpoint approach, they sometimes will swell before they shrink, or sometimes they can grow through the treatment. So there is this uncertainty. In general, the radiosurgery treatments are effective, so I kind of want to be proven that this is progression before I would act on it. So we have some different MRI techniques with us, what's called a SPECT scan or MRI with perfusion. They can give us some information that, again, they're not perfect, but they can tell us if things are pointing more towards necrosis or treatment effect, or more towards progression or cancer coming back or regrowing. If you really can't decide, we can always, potentially depending on the location, do a brain biopsy. So this is an area that I deal with almost weekly. There's always some uncertainty. Typically we would treat with steroids either way to treat the symptoms, whether it's from necrosis or disease, and then try to make as best educated discussion as possible on what we should do about it.
Thank you, Dr. Brownlee. Ann?
Next question is, what about proton beam therapy, and how does that compare with whole brain radiation or SBRT or stereotactic?
Yeah, so I briefly mentioned, so protons are a good tool. How radiation works is it does pass all the way through our body. The dose is decreased as it goes through us. We can aim it by using mini beams, just like spotlights on a stage, they meet on the target. Protons, we can actually have a stopping point where they don't exit through our body, so we can aim them a little bit more precisely. So they're mostly used when we have a specific normal structure that we're trying to avoid. Currently, they are limited in what we can use protons for, which comes down to a cost. They're very expensive to generate protons, so there's a limited availability of treating patients. When it comes to brains, for all kids, we prefer protons because any of brain we can avoid in a developing brain can have long-term benefits. When it comes to brain metastasis, there's very little benefits to protons in the upfront setting. They still would do whole brain with protons, or I don't even know if they can do SRS with protons, but it's not very beneficial. When it comes to treating the spine, which I didn't get into much, but we do this a lot in kids with cancers that tend to spread to the spine, the protons can avoid a lot of dose to the body, which can be very helpful. So if I have someone that needs what we call craniospinal radiation, I do send them to the proton center we have here in Dallas. When you're doing repeat treatments near the brainstem especially, there is benefits to doing protons. So in the retreatment setting, there may be a benefit. But in brain mets, I would say protons are pretty rarely used.
That was actually, I think you answered one of our questions here, is that treatment for two different brain mets, one completely responded, the other one was left at 5 millimeters. Is that a place where you would consider proton?
Probably not. I don't often refer for brain metastasis treatment. Watching after treatment, so small lesions may disappear. Bigger lesions typically will leave a scar or leave a mark, so we have to watch. Just because we still see something after radiation doesn't mean that it's alive. Again, cancer likes to grow, so if it's stable on scans, it is likely just a scar. So when it comes to retreatment, we do have different tools. We can do radiosurgery after whole brain radiation. We can do repeat radiosurgery. We have different neurosurgical techniques, including things called LIT and other treatment tools for recurrent brain metastasis, or we have surgery as well. So there's other tools, but proton's not typically a part of my treatment regimen for this.
And what about LMD? Would somebody with LMD be a candidate for proton?
Yeah, so I think that would be one. Oftentimes, I don't see a lot of LMD in my practice. Often when I do, they are typically pretty sick when it comes to their extracranial disease as well. LMD for adults is a little bit harder to treat than in kids. Also, the cancers we see in kids tend to respond a little bit better. So theoretically, you could do what's called craniospinal irradiation, where you do whole brain radiation and you treat the entire spinal cord. I've not done that in adults myself. I would send them for protons to see what they think. I typically would do whole brain radiation if they haven't had it, and then kind of target spots in the back if they're symptomatic. And then oftentimes I would refer them to my medical oncology colleagues for different drugs that can potentially treat these areas, I think safer than I can.
And speaking to that, so, LMD, leptomeningeal disease, means that it's in the lining of you hear about the dura mater. It's the lining of the brain and the lining of the spinal cord. And so it's harder to pinpoint because it's in a lining, right? And so that's what makes it challenging. And so we might see little nodules or enhancements on the lining of the brain. And so we have seen a lot of exciting data anecdotally with some of the treatments, like in non-small cell with osimertinib at higher doses, double doses, as well as in small cell lung cancer with tarlatamab. I think we're going to see some of this with these ADCs, those biological missiles, those Trojan horses, because those get into the brain as well. So I think we're seeing it, and hopefully, sorry, Zach, avoiding proton CSI. Because we can do something that's a little bit more targeted to the cancer and avoid those areas, try to sterilize the lining of the brain and the lining of the spinal cord to help patients. And while LMD is a very serious diagnosis, I think hopefully we're going to start seeing many, many, many successes with the new therapies.
The next question we have is about side effects, and do larger lesions cause worsening side effects than smaller lesions? And is it beneficial to make sure that you treat lesions at their smallest?
So I would say in general, most people with larger lesions have more symptoms at baseline. So brain metastases don't by themselves inherently cause neurologic effects, but as they grow, they cause kind of irritation, and our immune system is trying to get rid of them, so they cause swelling or edema. What I always say is when you get swelling in your hand, you get a bruise, it hurts, but it's not a big deal. When you get swelling in your brain, our brain is surrounded by the skull, so there's nowhere for that swelling to go. So the bigger the lesion, typically the more swelling, the more symptomatic you are at baseline. So with treatment, those patients will actually feel better as the lesion shrinks. We use steroids as the first Band-Aid, and then after we treat the lesions, we can get rid of the steroids. Side effect-wise, when it comes to whole brain, the size of the lesions won't affect the side effects at all. It's from treating kind of the inherent normal brain. From radiosurgery, we do know that the larger the lesion is, the higher risk there is for that necrosis, which can happen after treatment. So some of the strategies to mitigate that risk is to fractionate that radiosurgery, where we'll do 3 or 5 treatments, which still allows us to have good disease control, but less risk of that necrosis. With radiosurgery, the control is going to be a little bit better if we treat them when they're smaller. So this is a benefit of treating when we see them.
And I think here for our smashers, it's really advocating, if you haven't had an MRI of your brain recently and something changed in the body, always advocate for an MRI of your brain. If something changed in your body, we got to make sure nothing changed in the brain, right? Like many
totally
times, spots in the brain don't cause symptoms, right? And so that's where the key to having regular surveillance, regular imaging. MRIs are key here. CT scans, if you have a contraindication MRI, like a pacemaker or something, hardware. But really making sure you're advocating, if you haven't had one for a while or things change in the body, ask your doctor, is this the right next step for me, so that we can catch it early and make sure that we move forward in your care.
Yeah, I think if anything, that might be the best advice from this topic. Is MRIs are key. The medical oncologists are treating a lot of patients they might forget. When I see them, I'm always making sure we get the MRI brain. So I like every 3 months for most patients. Again, when they're doing well, you could probably spread it out. But anytime things change here, we always have to recheck up here too.
I think we have some non-small cell survivors that are also listening in and here today. And so the question is, are there any differences in the way you treat brain mets between small cell and non-small cell?
In general, yes. Non-small cell we treat like every other cancer, where I do very, very little whole brain for non-small cell. I do SRS for almost everything. With small cell, this is where we're trying to see if we can use the strategies we use for every other cancer type safely without increasing the risk of having the cancer in the brain get kind of out of control, which I suspect all the trials are going to show is the case.
Yeah, and thank you to our I guess, Smasher supporters for listening in that are our non-small cell colleagues. So thank you for listening in and being part of that. And I know we also have our transformation tribe of our transformed small cell who are part of our Smashers as well. Do we have any additional questions, Anne?
The last question is really about, are there any long-term effects from radiation in terms of causing a cancer itself?
Yeah, so part of my discussion of the side effects for every single patient I treat is we use radiation to cure cancer. As a byproduct of that, we do damage the DNA of some of our normal cells. When our normal cells repair that damage, every once in a while our body makes a mistake and it can cause a mutation. If that mutation happens to occur in a critical tumor suppressor gene, it can actually cause a cancer. So this is why we don't use radiation kind of willy-nilly anymore. We don't radiate people for their shoe size or their hat size. We don't use CT-based scans unless we really need to. For therapeutic radiation, the doses are higher. We do have a higher risk of causing what we call a secondary malignancy. I typically quote the risk at about 1%, 1 out of every 2,000 patients will get radiation-induced malignancy. It typically takes 15 to 20 years from radiation to getting one of these. A lot of this data is older. As our fields are shrinking and we're more precise, likely these risks are lower, but it is a risk. When it comes to the brain, oftentimes the benefits far, far, far outweigh the risk. So I would say it's something we bring up, but I don't think it's something that should be kind of worried about.
And I have one question personally. So, you know, we have a number of our Smashers who are on tarlatamab, and maybe everything is going exactly right, shrinking, there's no new spots, they're feeling well, they're on therapy, but then a spot pops up in the brain or a few spots pop up in the brain. Can you speak to kind of management of oligo progression on tarlatamab?
Yes, I have similar patients. I've been impressed with this new therapy. I have seen patients that I've treated that were chasing at straws. We burned through immunotherapy, we burned through lubernectin, and it's been pretty much a wonder drug. Most of those patients have had brain metastasis, so I've been watching them. I do see some CNS responses. I've also seen a few patients where the brain kind of acts up. In general, just because the brain is acting up doesn't mean the body's going to act up. They can have kind of, again, even though it's getting into the brain, it's probably not quite as effective. So I do a lot of radiosurgery for those patients. You always have to, I have one patient that I've done radiosurgery and he had kind of a flare-up, which we see in non-small cell. When we have good responses in the body, sometimes we actually get this kind of radiation recall or necrosis in the brain, which I've seen on patients on immunotherapy or targeted therapies as well. So you always have to make sure you're not over-treating.
I think it's a really important point. So I think with that, we'll wrap up this session, and that actually wraps up our Small Cell Smashers live session for today. So from the bottom of my heart, I know Anne's heart, and the LUNGevity team, we thank you for being here. I have a few points. Dr. Brownlee, I think you just literally mic dropped, right? So first and foremost, thank you, Molly. Thank you, Dr. Brownlee, for being here. Thank you. Let's give them a round of applause.